Well, I was asked to do something old, but I would like to talk about something more modern than ablative functional neurosurgery. So what I did here is I got about 40 years to speak with you in about 20 minutes, 30 minutes. So it's basically a 40 years worth of work. First time I heard of radiosurgery, I went from beans to the beans, from the beans to the beans. When I was in Brazil, in the middle of the country, I read a little book written, a chapter written by Gelberg, and there was, I'm treating pituitary tumors with beans. And Brazilian understood that beans were beans, right? We eat a lot of beans there, feijoada and all that. So I went to studying it, and I went through the books. I arrived to Harvard to find out that were not beans, or just beams, you know. And from there, I fell in love with the beams, and I went on and on studying this. My life turned a career improvement when I got a second brain. I had only one, and then Dr. Gorgulho, it's sitting there, is the second brain. And you see that a lot of the work that I present here, she did with us. It's a great improvement in our publications when she came in. I will talk with you a little bit about history, and then technologies that compete with us, radiosurgery, and then radiobiology of what I think is the radiobiology of the neurosurgeon. You saw the radiobiology, classic radiobiology with Minesh, very well presented, extremely basis of everything we do. And then I will just brush through some diseases that I think are important for the future of radiosurgery. As you look at this here, the ablative radiosurgery, neurosurgery, and radiosurgery, we go from radiofrequency ablation to radiosurgery, which are the techniques that are extremely important in lesioning the brain. But the historical trials went from mechanic to the cold lesions, right? Freezing lesions in the brain with bleeding, but very sharp, causing a lot of edema. Obviously, the lobotomy mechanic lesion. And then we went to the ones that the thermal lesions became perfected with radiofrequency. And past 70 years, we are using radiofrequency, still using radiofrequency. And then there was the induction of pellets in the brain, traveling to the brain, difficult to fix the pellet in the brain. So this is still under study, and probably will become one day a good way of making lesions. The cryo lesions I already mentioned. And then came the ultrasonic lesions. This comes more than 50 years old already. We are talking about HIFU as a new technology, but this was tried before and was abandoned for reasons of difficulty crossing the skull. You had to open the skull to do that, but now that's possible. And then, obviously, the radiosurgery lesions was extremely popular and really took over with the imaging. Just to sit us where we are in medicine, I think it's important. This is a slide I made some time ago, and I keep on adding things here because it tells us that 200 years ago, 300 years ago, we were dying when we were 40. And now, it came antibiotics, good surgery, we arrived to 60, came the cardiologist, got us to 80. And now here we are with our brain falling apart, and we need to do something about our brain. Came the COVID with RNA, right? And that showed the humanity that either you understand this well, or you're not going to go very far. The Homo sapiens needs to keep on walking and moving. We are the only species that keep on dominating everything, but we haven't dominated the basic one of the first ones that is the viral species that threatens us all the time. So I'll discuss a little bit of this journey with you. And you see here all the techniques of making lesions in the brain, which is the title of my lecture. Radio frequency persists, the cryopole making lesions very sharp, but today it's still used in pain quite a bit. The laser is becoming very popular. Microwave, I haven't seen this used. High-intensity focused ultrasound is in fashion. Will this really be the one for functional neurosurgery? It's presented as the best technique for functional, but you have to see it. But radiosurgery really is the only one that we can actually work in the molecule of DNA. You know, we are doing what genetic engineering is doing. We are breaking this. And I'll discuss a little bit of our findings in 2001 when we really fell in love with this idea of changing the molecule of DNA. But let's go there with Lexell, the first gamma knife at UCLA. The lesions were well defined, and they were copying the radio frequency lesion. You see a radio frequency lesion here. You see a double lesion. When we do that with double isocenters, when you do double shot with the gamma knife. The first gamma knife that I presented to you in '68 was made and was at Sophia Hammett, and was made not with a circular collimator, but with a slit collimator. And this was the one that went to UCLA, donated by Dr. Lexell after the cobalt was almost done. It's a smart guy, right? We know he was a smart guy. So this arrived there already without cobalt, but it was used for a while. But you see that Lexell had already done the study of the lesions quite well. They were all very sharp, great histology done by this group, by his group. Well, our group at UCLA, this is 1997, so this is the first 7 years I was at UCLA. I was already in love with minimally invasive therapy of the brain. And I got a good colleague, a radiologist, neuroradiologist, and we had trying to experiment even with lesions of radio frequency inside of the MRI scan that we end up abandoning because we had a lot of artifacts of the radio frequency inside of the MRI. It didn't work then. But we destroyed some tumors at that time, but really the laser, it was done in Germany at that time, and that was in Englagen, and they really developed it quite well, and we see today a technique that's very viable. Radio frequency, we did quite a bit of radio frequency in the past, mainly with the palidotomy, thalamotomies, and at that time we were all very confident that this was a good way of making lesions, and it is. It's actually the best way of making lesions if we compare with anything else, because immediately it gives you also an electrophysiology. But what we saw as well is that we do have a little bit of ischemia around that lesion. There is a penumbra area, and we got some complications and reported that about 3% of our cases of palidotomy. And I came across to this finding then that we were at that time trying to see if we could do a 3mm collimator. Extremely small and precise, using a linear accelerator at that time, the Novalis. The physicists always told me, oh, you cannot measure 3mm collimator dose. And I asked them, how much can you, what's the precision of your measurement? Oh, we'll be off 3%, 10% here, 10% there. I said, well, we don't know what means 10% in the dose of radiosurgery, I guess, until today, right? We are with 16 gray, 18 gray. We are always moving. I said, well, let's do it. And we did in the monkey first. And this was a great finding because with immunohistochemistry, we found that if you're irradiating the substantia nigra, then you got tyrosine hydroxylase, that's precursor of dopamine. So suddenly here is a neuromodulation that we didn't see before. Nobody was talking about this before. And so this is really the technique that allows us to go and make a break in the molecule of DNA. What we don't know is how to fix that break. You know, we let Mother Nature to do that, and that's why we are not knowing time, volume, how much you should give to modify this situation. We have to understand the gene modification and understand the gene therapy, engineering of the gene for us to take advantage of the quality of machines that we have now in our hands, the precision, and really be able to study so we can start to become very selective to each one of those cells. I don't know, is it mine? Oh, I have 10 minutes to speak still, so it's, I thought that was John telling me to shut up. But let's go there. We need to be precise, right? The optogenetics is really a technique that allows us to go and be very selective in the cells of the brain. You know, beautiful lecture you just heard about it. You know, this is obviously cartoons that are not mine, but they do explain to us where we need to get to be able to understand the cell and the modifications we do with radiation. We need to break the chromosome and really correct it. This is already done, right, with genetic and engineering. That's why we have so much wheat, so much corn, so much food in the world. We were supposed to be starving now, and we will always have food in this world because we can change the genetic of the vegetable and even of animals, and we can produce more food for the humankind, for the Homo sapiens. But we need to break the molecule and know how to fix it. Take the code that is wrong, the genome, the code that's wrong, and put the correct one. And if we can do that with radiation, and we can find out what we need to do after we make the break and go precisely and fix it, this is where this modulation research that we are going through now has to go. And I will discuss with you why I'm saying that. Obviously, functional neurosurgery is not a dent in the volume of radiosurgery. This is the data from Electa. We see that's minimum what we do today. And I'm very glad that John with ZAP has the vision of wanting to use this in functional neurosurgery. I have been working with all these machines through life, and I'm dreaming to have a ZAP in my hands. I think I probably will if I can talk to John a little bit for him to give me one for free. But let's see how let's see how it goes. but it's not because of that, because John really looked at the right reason why we should have a machine. If you look here at the price of a surgery, an open surgery, and if you look here at the price of a gamma knife, a LINAC, and with the ZAP that we don't need the whole apparatus that these machines that shoots radiation need, right? We don't need, it's already shielded, so we have a much less expensive in having these machines in the hands of surgeons, and thinking as a surgeon and having the knowledge of radiation oncologists behind helping us to treat the diseases in the brain, I think it will be a very important contribution to humankind. As you look at here, the obsessive compulsive disorders, it's one of the good indications of radiosurgery. You see that the lesion will cost approximately $10,000, while a DBS is $50,000. So we can treat 5 patients when you treat only 1. And moreover, if you look at this classic paper already in the literature, it's just a revision of the literature, a review of the literature. But what you see here, it's DBS is very nice in the first months, and then you have erosions, you have failure of a system, and all this, and then it starts to fall. And in the end, what's the best is really the lesion. Statistically significant at long term, the lesion with either gamma knife or radio frequency. It's better than the electrical stimulation. So we need to look at society in general with what is the best, most durable, and cost less for the patient. Now, the radiobiology of functional radiosurgery. I think this is extremely important here. Look at this, neuronal activation. We have seen that we do have a neuroactivation when we do a focus lesion in the thalamus, for instance. This was described by Dr. Lexell back then when they started to use thalamotomies for pain. Patients got no pain 2 days after. Pain comes back and it would get better only later on. So there is this activation, this change of the tissue immediately after the radiation. Then we have a breakdown of the blood-brain barrier. Glial cells, astrocytes, you see, they are part of the blood-brain barrier. The endothelial cells are part of the blood-brain barrier, and you see that in the enhancing MRI scan, you see that in the edema, you see a resolution of that and completely disappearance if you do a small collimator. This was a little girl that had a low-grade astrocytoma here in this place that we treated, a 9-year-old. And then completely normal later on, and the vascular lesion is very important. Why things happen later on? Because we do have obstruction of blood vessels with radiation. We see that from magnetic resonance images of AVMs as well as angiographies. We see that very clear. The effects of the vasculature is very important. And Dr. Song, a radiobiologist, showed that you don't need 10 gray, you need 6 gray to start to have changes in the vasculature. If you do 2 gray, then you are preserving vessels. That's why the radiation oncologist can take the brain and do 2 gray for 30 fractions, and the guy gets out thinking. So if you increase the dose a little bit, we start to have the vascular changes. For some reason, the thing got stuck. But, well, here are the functional lesions, right? You see here, we irradiate the thalamus with a dose of 140 gray. There's nothing there. And then you start to have the lesion is made. And this is already an acute and a late reaction. We start to see breakdown of the blood-brain barrier, and the lesion is being made. Here is already a breakdown of blood-brain barrier in a case of capsulotomy for OCD, and then you see the final lesion is a ischemic lesion. It's just obstruction of blood vessels. But what happened in the penumbra there? What's important is something has happened beyond a vascular lesion, and we can see that when you go to the laboratory, right? I told you that you can modify the cells of the endothelium and as well as the blood vessel, and what you have is an accumulation of collagen type 4. We showed it quite clear in the pig model with rete mirabile, and we showed also that this response is dose dependent. You can make the rete mirabile disappear in 5 months if you give 90 gray, while with 20 gray, it will take 2 years, 3 years, like an AVM when you treated it. So this is very well shown, the vasculature. So we are having an effect in the vasculature. When you irradiate the brain, so you have the vascular, you have the neuronal changes, and you have the glial changes. You have to think these cells in a different way, and they respond in a different time frame and functional frame. Right? So you have cell modification. If you take a radiosurgery in a hamartoma, this is a great model, human model of epilepsy, right? Because you have very well concentrated focus, you know where the focus is, and you give a dose to this, and you control the epilepsy in these patients. Dr. Regi has a large number of these. I hope he will show to us the nuances of the response of this epileptic format with radiation. Now, how much you need to stop action potential? We did that in slices of the rat, and we need 60 gray to stop the action potential. And here is control, here is 60 gray radiation. I don't know if you can read that, it's a little bit small. This is a busy slide, but it's almost our research over the years. Now, if you do radiosurgery in a kingdom model, epilepsy, we are talking about epilepsy, in a Kindle model, and we give 40 gray, the 40 gray that Dr. Ye was talking about, you have an activation of the model. It starts to, the rat starts to seize in the next few days immediately, many times, but then at the 3 months, you have a complete control of the seizures. The threshold for seizures go up, extremely up. And if you do a PET scan, then you don't have anymore the hot spot in the hippocampus of the rat, but you have a cold area in that region of the kindling. Well, this is vascular, this is neuronal, and this is probably glial as well. So we got a lot to study here to understand what's going on. What about axonal and Schwann cells? And one of the good models of these is the trigeminal neuralgia, and we'll discuss that a little bit. This is here a nerve irradiated with 90 gray, and you see that you have a loss of myelin, and you have still a good amount of neurons that are not denuded from the insulation, so they continue on working, and that's why we have control of pain without loss of sensibility. There is a little bit here, a little bit there of loss of sensibility, and we show that in our patients that if you increase the dose over time, at arrive a point that we stop having loss of sensibility, but we still, with larger dose, we still have a better and more durable result. And if you have radiation in the axilla, where we think that there is the demyelinization, and we enter inside of the brain stem a little bit, and this is what it shows. Significantly, these patients respond longer time, better, but they do have, you pay a price of a little bit more loss of sensibility. We talked quite a little bit about the immediate pain relief here. This is one of Dr. Gorgulho's work that she published at Curious. And you see that when the patient has immediately pain relief, that is way more durable than if you have over time pain relief. So this initial change that we see is extremely important in the results. In the epilepsy group, we study also the after discharges, and we see that that's all controlled with 40 gray at a long time. Well, in the animal model, when we did the 3mm collimator, we didn't see only that increase in tyrosine hydroxylase, but we see also the GFAP also increased. The growth factors are here increasing, the glial derived growth factor. Serotonin increases as well in that region, and glutamate as well, more related to excitability and lesioning. So it's very important that we can figure out what's going on here, and this, I never could get the grant that I wanted to study this, so we went to more clinical work, really. And here you see our work in OCD. It was reported by our psychiatrist, the outstanding leader of the group that has helped us, since we arrived there, treat these patients with OCD. And recently, this email arrived to me yesterday from the group from Bart Nutting. As you know, he is the one doing the RTCs, the randomized trials for OCD with DBS. And the question was asked, why the psychiatrist didn't send us the patients? And then a psychiatrist from Sweden said, well, our group doesn't have money even to do the basic treatment of psychiatry. This is Sweden. This is not a country that doesn't have an economy that's solid. They don't have the money to pay DBSs there for the population. 2 years waiting to have a DBS if you have OCD. So the explanation is they don't send it to us just because it's just not reasonable. The patients need to be cared for during this 2 years. It's just not an indication that's for them. Well, we already learned from all this. What we are seeing changes in secreting of hormonal, blood-brain barrier opening. This is not just a lesioning without any any nuances. This is happening because we are changing different cells at different moments and going through effects that before we didn't even talk. For instance, the abscopal effect, very in fashion with the radiation oncologist, right? Now we are getting drugs together with radiation to have lesions disappearing that were not even irradiated. So here they are already finding medications, 3 minutes. They are already 3 or 5? 3, 2, top 2. Okay, all right, so they are doing that. And where are we going? Are you putting electricity in everybody and doing all this work? We have finally learned all the wiring in the brain in a very nice way, and we're keeping on studying this in a way that we can get the targets well. We can get this tremor very well controlled. We know where the targets are. We know the target for pain, for instance. So we have a group of our students doing this and trying to show to us things that are becoming quite interesting. Moral motivation in the basal forebrain. So we try to understand that. What is, shall we arrive to a point that will treat diseases? I hope you can learn, can read what is this disease, you know, pedophilia, we have to take care of this. And obviously take care of our politicians that are lying, and my hope is that ZAP will do that for us. We did, I want to call attention for Barbosa and Paranhos. Those are 2 students from Rio de Janeiro that had done a wonderful job with us. I stole Barbosa from Casey. Casey took him from us, which was wonderful because he keeps on collaborating with us. And I have a good collaborator in Casey because he allows us to use Barbosa here and there. Thank you very much. But we did a mistake on this here. In my last 2 minutes, I will say this. We assume that we will control obesity with just increasing the metabolism of people, putting electrodes in the hypothalamus. And actually, we got a guy here that lost 69 kilos, but the other 5 patients that we implanted didn't because we increased the metabolism, they ate more and they stay with the same weight. So it's quite interesting how it goes. Well, targets for radiosurgery, we have Alzheimer's disease. I want you to think about the Luca-Mannheim here. You can probably treat. Targets for PTSD and autism, we have the amygdala. We have studied this, and it does work in the rat. We have here all the details in that book that the several targets we can use. Addiction. This is a work that we did with Lovo. It's in here. Dr. Gorgulho as well. Alejandra was a student in Colombia. And here they show that indeed radiofrequency lesions can control, and the accumbens can control addiction. So, and if we move into this in the near future, we'll do quite well. I would comment a little bit on that paper, but it was already very well discussed. So we are in the point where we challenge the group here of really understanding what radiation is doing in the brain to increase neurotransmitters. We have a large group doing that. We are spreading through Brazil a great number of people. That's what I want to do there in my second life. And these are my teachers from UCLA that helped me in radiosurgery then. Thank you very much.